Good afternoon and welcome. My name is Aida. On behalf of the Division of Healthcare Financing and Policy, I would like to call the meeting to order and verify that today's meeting agenda for the Public Option Design Session 5 was posted on January 11th, 2022 on dhhs.nv.gov and at notice.nv.gov. With that, I will pass it on to Emma to go over some housekeeping items.
Great. Live closed captioning will be available during today's meeting. Click CC on the bottom of your Zoom window to enable or disable. There are a few ways attendees may participate today. First, participants may submit written comments and questions through the Q&A box. All comments will be recorded and reviewed by the state. Participants may also submit comments and questions to nvpublicoption@dhhs.nv.gov. At designated times, spoken comment will be permitted. Participants must raise their hand for Zoom facilitators to unmute them to share comments. The facilitators will notify participants of appropriate time to volunteer feedback. If you logged on via phone only, press *9 on your phone to raise your hand. Listen for your number to be called, and if selected to share your comment, please ensure you are unmuted on your phone by pressing *6. If you logged on via the Zoom interface, press raise hand in the reactions. And if selected to share your comment, you'll receive a request to unmute. Please ensure you accept before speaking. Public comment will be taken during the meeting at designated times. Individuals will be called on in the order in which their hands were raised and will be given 3 minutes. Please state your name and organizational affiliation when you begin. Participants are also encouraged to use the Q&A to ensure all feedback is captured, or again, you may email comments to nvpublicoption@dhhs.nv.gov. The state will publish a public option FAQ and will continue to use this resource to inform the public and address design questions. And with that, I will pass it to Stacy Weeks.
Thanks, Emma. Good afternoon, everyone. So today's agenda, we're going to talk a little bit about provider contracting and reimbursement and networks, and then we're going to move into the discussion around health plan rate setting and rate review, and then some discussion about opportunities to strengthen the marketplace in Nevada. And then we're going to open it up to public comment, but briefly also talk about next steps for the design sessions and the work ahead. Next slide, please. So a little bit before we dive in about the meeting. Next slide. As you can see, I just mentioned these topics for today. The next session is January 28th from 1 to 2 p.m. Pacific time. And at that meeting, the topics that we will present will be licensure and oversight, offering the public option in the small group market, and also next steps, the actuarial analysis, subsequent opportunities for stakeholder feedback, and we'll discuss a little bit more about the waiver development process and public comment. Next slide, please. So just to kind of go over real quick the overarching goals today, the state is looking for feedback on a couple of topics here. These are some general questions, but obviously any feedback and thoughts and ideas are always helpful about these topics. Provider contracting is the first one, and networks, and this has to do with the idea that should the state think about requiring the products to meet additional network adequacy standards that are above and beyond some of the standards you see today in the individual market. The second one here has to do with health plan rate setting and rate review. How should the state agencies coordinate the rate review process to provide oversight of the mandated premium reduction requirements while balancing administrative burden, not only for the agencies, but as well as for providers and plans. And then the last but not least is thinking about, are there things that the state should be thinking about in the future and pursuing certain policies that could strengthen the marketplace in Nevada, specifically the individual market, and if so, which policies? Next slide, please. All right, provider contracting and networks. Next slide. So in the statute that was passed, there are several design decisions that were already laid out. There are a couple here. The first one is what we refer to as the provider participation requirement. This applies to healthcare providers for the public option who participate in the Medicaid program today and contract in a network, or participate in the public employees benefit program, or who provide care to an injured employee pursuant to the state's workers' compensation program. So if a provider falls into one of these categories, what it means is that these providers must meet certain criteria. And the first one is they must enroll as a participating provider in at least one network of providers established for the public option. And they must accept new patients who are enrolled in the public option to the same extent as they would accept new patients who are not enrolled in the public option. So you have to treat them the same, essentially. So it's important to note, though, that these requirements around the provider participation requirement may be waived when necessary by the director of DHHS to ensure that Medicaid enrollees and those receiving benefits from the state employee health plan have sufficient access to covered services. In addition to the provider requirements, the law also requires a health plan participation provision, and includes, basically it requires health plans to submit a good faith bid proposal to the director of DHHS in the public option procurement if they want to bid and participate in the state's Medicaid managed care program. Next slide, please. So another key design decision that is outlined in the statute has to do with provider reimbursement. So in the statute, it requires that provider reimbursement rates under the public option are in the aggregate comparable to or better than Medicare rates for providers today. This provider reimbursement requirement acts as a floor and is calculated based on aggregate reimbursement rates in Medicare. And it also includes, when we think of this floor, it would include any add-on payments or other subsidies that that provider may receive under Medicare. So that would sort of be their floor, and no rates could be any lower than that. There are a couple exceptions in the bill for specific types of providers. The first one is for providers today who receive cost-based reimbursements under Medicare. The public option, the legislation requires that the public option reimbursement rate must be comparable to or better than the cost-based rates provided for that provider today in Medicare. So essentially, the health plans and contracting with providers could not pay cost-based providers under Medicare today any lower than those cost-based rates today. The other exception is for FQHCs and rural health clinics. Their reimbursement rates must be comparable to or better than the rates established for patient encounters under the applicable prospective payment system. And when we're talking about PPS here, we're talking about the one that's used in Medicare for these providers. So the rates could not be any lower. They could be higher, but they cannot be any lower than that floor. The third exception is certified community behavioral health clinics, CCBHCs in Nevada. Their reimbursement rates under contract with health plans who offer the public option must be comparable to or better than the reimbursement rates established for them today under the Medicaid state plan. And we're talking there about an alternative payment methodology that the state is using to pay them. Next slide, please. All right, so the other piece here is thinking a little bit, I think the state is looking for feedback on, is around network adequacy. So the statute does outline, the basic bare minimum. So the products that are offered in the individual market as public option plans, they must meet the standards in the individual market for similar policies, right? For QHPs, for individual policies of health insurance. But there is latitude and additional design considerations in the legislation for the director to consider in the procurement process. So some of these are outlined here on the slide. For example, during the competitive procurement for the public option, the director is asked to look for opportunities to reward plans and the procurement scoring that demonstrate alignment between Medicaid managed care and public option provider networks. It's also looking to include and make sure that plans are including safety net and other cost-based reimbursement providers. Also to think of giving some preference to proposals for strengthening the workforce in Nevada, specifically primary care, mental health, substance use disorder, and in rural areas of the state. And also looking to reward approaches that decrease disparities among different populations in the state and expand access and support culturally competent care. So any ideas and thoughts that you might have, I think is sort of the expectation here is to help think about what type of alignment between, for example, between Medicaid managed care and public option networks would be helpful for consumers as well as providers and plans, right? Even from an administrative burden perspective. The example here on the slide is something to think about. Colorado has recently created cultural competency network adequacy requirements So that carriers do not achieve savings by further limiting networks. The network must be no more restrictive than the most restrictive network that the carrier offers in a non-standard plan for the metal tier in that region. Carriers must ascribe their efforts to construct culturally responsive networks to the state, and they must include a majority of essential community providers in their service area in that network. So it's an example of something that could be added to the network adequacy standards for the public option plans through the procurement process. That would be a standard above the minimum requirements in the individual market. Next slide, please. This slide here does a nice job of kind of highlighting the differences between what we see in Medicaid in terms of network adequacy for health plans and providers versus what's today what you might think of as the individual market and the exchange, the QHP network adequacy. I think the big question here is to think about, are there things in Medicaid that might be helpful in the procurement to add to plans that are participating in the public option as in alignment, right, between these two markets. So for example, Medicaid today monitors both in its fee-for-service network and MCO network adequacy standards. They look at time and distance standards, for example, and provider to member ratios for primary care and specialists. That's one example. They also collect data and monitor access, and there's something to think about whether or not it should be applied to managed care, but as well as a public option as a way to sort of monitor and think about are consumers getting the access they need, and if not, are there ways to adjust for that. On the QHP side, the standards that must be met are the same as the ones you see today, and the exchange relies on Department of Insurance to conduct its network adequacy review for QHP certification. So the same would apply here. I think the question is, should there be a little bit more of a standard, maybe like a little higher level stamp of approval as a public option plan? As specified in statute, there is a Network Adequacy Advisory Council that provides network adequacy recommendations to DOI Commissioner. Again, those standards would still apply to these plans, but I think again, the question would be, should there be additional requirements? So should DHHS use its contracting authority to require basically the public option to have additional network adequacy requirements that go above and beyond these requirements by the council and applied to public option plans? Like I said earlier, it could be different things that are Medicaid today that you might want to see aligned in the private market, just for ease for consumers transitioning, ease for providers, and serving patients as they move across markets, or just in general administrative efficiencies for health plans. Next slide. Oh, okay, I'm going to turn it over to Anne. Anne, it's your turn.
Great, thanks everyone. So the next topic that we wanted to talk about was health plan rate setting and rate review. So as you can see here, the statute sets out some requirements that year one premiums be 5% below the reference premium from before the public option was implemented. So that is pretty straightforward how that will work. That as part of the procurement process, there'll be a requirement that those rates are 5% below, subject to, again, the potential for the state to waive that requirement if necessary, but again, that's the target. And then similarly, there's a requirement in the statute that by year 4, those premiums will be at least 15% below the reference premium, which raises the question about how are rates reviewed during years 2 and 3. So because the public option product will be a qualified health plan that will be offered on and off the exchange, just like any other QHP product, DOI will be involved in the rate review process, and that would sort of proceed normally. But in addition, for the public option, we are envisioning that the state would have, the Department of Health and Human Services would have a role in reviewing those premium proposals to ensure that they're hitting the premium rate reduction targets. So one of the questions that we had that we were soliciting public input on has to do with how the agencies can coordinate to minimize administrative burden, recognizing that there'll be another entity who is another regulator who's involved in reviewing the rates. That was one piece that we wanted to get some on. Next slide. Then the next topic that we wanted to touch on was strengthening the individual marketplace. And here, I think the biggest piece of public input that we need is really what it means to define success. So what exactly would it look like to have a stronger marketplace? Does that mean there are more carriers, that there are more plans offered, so sorts of different designs, lower premiums, lower cost sharing? What exactly does that look like in terms of a stronger marketplace? We've also heard that network adequacy, as Stacy had talked about previously, is a real significant concern. So maybe that actually the strongest, as opposed to saying we're strengthening the marketplace with respect to carriers or plans, instead really what we're saying is we need to strengthen network adequacy to ensure that people can use what they have. So interested in input on that. We also recognize that there's this need to have a level playing field. So we do need a unique public option product that is targeted at solving some of the challenges in Arizona. So whether it's, in Nevada, so whether it's a different cost sharing structure, a more robust network adequacy requirements, but at the same time, we know that this public option product is going to be offered on the exchange, competing alongside other QHPs, and sort of how do we understand exactly what that looks like to ensure that, again, any public option requirements do not, sort of lead to any changes in, the carriers or plans that are offered, or that any of those changes are to the benefit of the people, the consumers in Nevada. And we note here again, when possible, we recognize there'll be multiple agencies regulating these products, and so there needs to be some degree of coordination to reduce administrative burden. Separately, we think that there's some options to consider how to strengthen the marketplace. So reinsurance, which we'll talk about in a second, we know that's something that's been debated in the past in Nevada and has not been something that's been taken up just yet, in part because of the financing, which we'll talk about again in a second. But that could be one tool. And then the other is to think about whether you can use the public option procurement process to change the cost sharing design. Again, if what we think of a stronger marketplace really is having products that people are more able to use, so whether it's lower premiums or more affordable cost sharing structures, is there a way to use that procurement process to actually have more attractive cost sharing structures? So then on the next slide, we'll just touch on reinsurance a bit. So 15 states have implemented a reinsurance pool through a 1332 waiver. A prior actuarial study concluded that external funding was needed for reinsurance in Nevada to be successful, and there was not a source of readily available funding that was available to fund that reinsurance pool. So pass-through funds may provide most, but likely not all of that external funding, and so there is a need for some degree of additional funding. The way that reinsurance pools work is that they provide subsidies to carriers for high-cost enrollees, and in competitive markets, that subsidy may reduce enrollee premiums. It can reduce risk to carriers that join the marketplace, especially for the previously uninsured populations with an unknown risk profile. So as you're pulling new people in to the marketplace, again, carriers are not sure exactly what the health needs of that population will look like, and so pricing is challenging. Reinsurance can reduce the degree of risk associated with that. But it does require dollars. So most states use a combination of pass-through funds from the 1332 waiver plus insurer contributions or state appropriations. So a 2019 actuarial analysis estimated that a reinsurance program in conjunction with a 1332 waiver could reduce average market premiums by 13%. For annual savings of around $780, but that external funding was necessary, and external funding was not identified at that time. So there's this opportunity to have a reinsurance pool that complements the public option that could strengthen the marketplace, but again, there needs to be a source of funding for that because any pass-through funding generated likely would not be sufficient to cover the entire cost, and that remains uncertain. So interesting action on that. Next slide. Okay, so then we just wanted to touch on the next steps. So again, you can visit the public option webpage for regular updates, or you can submit questions or comments. You can write to nvpublicoption@dhhs.nv.gov, We also welcome you to attend design session number 6, our final design session, next week on Friday, January 28th from 1 to 2 Pacific time. That session will focus on licensure and oversight of the public option plans, offering the public option in the small group market. We'll talk more about the upcoming actuarial analysis and what that will focus on, and we'll highlight subsequent opportunities for stakeholder feedback. We'll really lay out the process for where we go from here over the next year before submission of a 1332 in early 2023. And with that, I will turn it over to Emma to facilitate our public comments.
Great. Looks like we have one hand raised at this time. Helen Foley, I will go ahead and allow you to unmute.
Thank you very much. My name is Lily, representative of Association of Health Plan. We have another letter forthcoming from the association, but we wanted to touch on a couple of points, many of which were previously highlighted at the January 5th meeting regarding rate setting and review. Any premium, regardless of the variable premium reduction threshold, actuarially sound, means an appropriate premium must overtake individuals enrolled in these plans.
Helen, I'm so sorry to interrupt you. You were having a little bit of trouble hearing you. I think there's a little trouble with your audio connection. I wonder if you'd like to disconnect and try reconnecting, and then when I see you pop back up in the queue, I can call on you again. Okay, I'm going to go ahead and call on our next person, and we will come back to Helen. Patrick Kelly, you should be unmuted at this time.
Good afternoon. My name is Patrick Kelly, and I'm the CEO of the Nevada Hospital Association. Hospitals are concerned about the adequacy of the public options networks and the potential impact for access for all Nevadans. We believe the state should pursue policies and initiatives that strengthen the entire healthcare marketplace. The state should make great efforts to avoid skinny networks that restrict or offer a limited number of healthcare providers. Networks should be required to meet community-wide standards of accessibility in terms of patient appointment times and proximity to covered entities. Every emergency room in the state must be included in every network because people tend to go to the closest emergency room in their community. Consumers experience too many negative events from skinny networks. The public options plans, whether they are administered by private MCOs or the state, must negotiate fair reimbursement levels that will populate the networks with accessible providers. The Nevada Health Workforce Research Center recently published a new report titled Physician Workforce in Nevada, a Chart Book. It doesn't paint a very pretty picture. Nevada ranks among US states as currently 48th for primary care physicians. Currently, in 33 of 39 physician specialty areas, Nevada is below the national average, including general surgery, pediatrics, and psychiatry. Nevada needs an additional 1,589 physicians to meet the national rate of physicians. Other publications estimate Nevada needs more than 4,000 registered nurses and 3,400 licensed practical nurses to reach the national average. An estimated 2.1 million Nevadans, or 67.3% of the state's population, resides in a federally designated primary care health professional shortage area. These statistics beg the question, can the public option truly have adequate networks if the providers don't exist? The promise of the public option is to improve access to healthcare. If a provider shortage exists, people have to travel great distances and appointments take months to schedule. Will the promise be fulfilled? Adequate networks will never exist in Nevada until the workforce shortage is addressed. The state needs a comprehensive plan to educate and recruit healthcare providers to the state. Because the public option must be 5% less than the reference plan, its rates will go through a thorough vetting process. The Division of Insurance will verify that its rates are actuarially sound. This rate setting process must be as transparent as possible. Citizens purchasing public option coverage must be confident that their plan will be sustainable. Thank you.
Thank you for your comment. Next, Helen, looks like we've got you back. Helen Foley, if you're able to unmute.
Yes, I am. Can you hear me now?
Oh, yes, that sounds great. Thank you.
Wonderful, wonderful. Well, I'm Helen Foley, representing the Nevada Association of Health Plans. We will have another letter forthcoming from the association, but I wanted to touch on a couple of points today, many of which were previously highlighted at the January 5th meeting. Regarding rate setting and review, any premium, regardless of the variable premium reduction threshold, must be actuarially sound. This means an appropriate premium must be charged in order to protect individuals enrolled in these plans, the providers who provide services to individuals, and the state of Nevada or the insurer who ultimately is responsible for these claims. While the public option is required to meet all state and federal laws and regulations applicable to insurers, to the extent that such laws and regulations are not waived, the rate review process and reserve requirements are fundamental requirements that should not be waived. Therefore, capitalization and reserve requirements should be met to assure solvency of the plan for the consumers and providers. If reserve requirements are not met, then providers may see delays in payment for services that they have already rendered, which ultimately impacts individuals who are attempting to get medical care. Regarding benefits and network, the association believes that existing state network adequacy requirements already in place should apply to the public option plan. The existing network adequacy determination process includes a network adequacy council with diverse representation of insurers, providers, and public members. The council holds multiple public meetings each year and makes recommendations to the insurance commissioner. And then finally, strengthening individual and small group. With the individual market, there continues to be an expansion of individual coverage options in Nevada's exchange marketplace, with the addition of 2 new entrants in 2022 for a total of 7 insurers. It was recently reported that record exchange open enrollment numbers show 14.2 million Americans have quality, affordable coverage, many with even lower deductibles under the American Rescue Plan. As a result of ARPA, the amount of federal subsidies increased and expanded the number of Nevadans who qualify for those subsidies. And with the small group, currently there are various coverage options for small groups in Nevada that include association plans, stop-loss plans, and the ACA plans. Thank you so much for hearing our position on these issues.
Thank you for your comment. Next, I will call on Christine Saunders. Christine, you should be able to unmute now.
Good afternoon. My name is Christine Saunders, and I'm the Policy Director with the Progressive Leadership Alliance of Nevada. We want to thank DHHS and MNOT for continuing to engage stakeholder groups with these productive meetings on how to effectively implement the Nevada public option. For the past decade, healthcare costs have risen exponentially faster than inflation, and while Nevada families and small businesses have struggled to continue to secure access to insurance, Nevada's for-profit hospitals and private insurance companies have reported record profits. What is striking is that even as these companies decry public option as a threat to Nevadans' access to healthcare, their own business practices are undercutting better healthcare outcomes and coverage in state. They fought ending surprise billing efforts so they could raise prices while confusing consumers and regulators on what is actually driving cost increases, other than increased corporate profits. The truth is, the biggest threat to Nevadans' access to healthcare providers and better healthcare outcomes are these corporations' bottom line. We encourage you in the legislature to take the discussion about public option and include a broader look at licensure and oversight that brings true transparency efforts to Nevada, that makes insurance companies and for-profit hospitals completely and comprehensively open their books. Nevadans need to understand why the same procedures have dramatically different prices depending on what hospital you go to and what insurance you do or do not have. Nevadans need to understand how corporate health insurance companies are able to negotiate with for-profit hospitals to lower costs for their products while forcing price increases on other healthcare consumers. Nevadan families should not be subsidizing corporate profits. It's wrong. We appreciate DHHS and Manat exploring how to increase transparency and oversight of all the players in Nevada's healthcare market through licensure and regulatory processes. Thank you.
Thank you for your comment. At the moment, I do not see any other hands raised. If anybody else would like to comment, please go ahead and raise your hand at this time. Okay, I think we can close public comment.
Thank you, Emma, and thank you everyone for your participation and for joining today's meeting. We are adjourned.